Welcome to Advanced Operations Module 2. Our first topic we're going to cover is crew resource management. A lot of us utilize this without even knowing what it is called. The objectives for this first portion are going to be to define crew resource management, discuss the origins, describe how crew resource management works, identify ways that crew resource management can be used in EMS. So the inherent nature of pre-hospital medicine, it's dynamic, it's unpredictable, and can be very dangerous. It's nearly guarantees that things will not go according to plan, even if you think you have thought of everything that could happen and you have trained so well for it. Equipment fails, it doesn't work right. Batteries fail, they lose their charge. They can in an instant lose their charge too. Environmental factors all unite to derail a situation at which performance must be at the absolute highest. So when you think you're bringing your A game, you go in to intubate with a video scope and the batteries instantly fail, or you get a green screen or the screen is cracked. And now, how do you think outside the box? Now, what do you do? What is your procedures? We'll discuss how to apply crew resource management principles in crisis situations. So crew resource management is training procedures to use environments where human error can have devastating effects. It's primarily used in aviation safety, and it focuses a lot on communication, leadership, decision-making. The founder of it was a guy named David Beatty. I believe I'm saying that correctly. He was a pilot, and he wrote a book in 1969 called The Human Factor in Aircraft Accidents. In 1977, at Tenerife Airport, two Boeing 747s collided on a runway. This killed 583 people. A few weeks later, NASA held a workshop on this specific topic and promoted the crew resource management type training. It formally began in the United States with a recommendation by the NTSB air safety investigator and aviation psychologist during an investigation of the 1978 United Airline Flight 173 crash, which happened in Portland, Oregon. So this crash happened because the airplane ran out of fuel while troubleshooting landing gear problems. In 1981, United Airlines was the first airline to launch a comprehensive crew resource management program. And right now it is the golden standard. It's born out of necessity. It needs to improve communication between professionals in a high tempo, high risk situation. Firefighters and wildland firefighters, EMS, all the way up to the captains and administration in the public service. Police officers and law enforcement can utilize crew resource management. Not just pilots and air crew. Crew resource management was also created to mitigate that human error in aviation. A lot of wrecks can come from human error. A lot of them were not doing pre-flight checks how they were supposed to. They were not spinning bolts that needed to be spun or tightening things, doing a walk around appropriately, making sure that the doors were completely shut. I fly on a helicopter, and about 22 years ago-ish, the back compartment wasn't closed all the way, but you could close it and it would stick. And the aircraft at my base, it popped open once they were at altitude, in a sheet, a hospital sheet, a white sheet that we all pick up at the hospitals and wrap our stretchers with or cover our patients with, we had an extra one in there. And the sheet fell out of the back compartment, but got caught up in the tail rotor. It flew straight into the tail rotor. They had a hard crash landing, so to speak. They rotated down and got down where everybody lived and survived. There were injuries, and there are some amazing interviews with the flight nurse, I believe, and the pilot. I believe the medic as well. That's just one of many wrecks that happen, but it's one of the few where everybody have survived. Most of the time when there is an aircraft accident that is up, especially from in the air, you're not going to get a lot of survivors. And your best hope is to glide down, right? Somebody who is in a little Cessna by themselves can hopefully know how to get themselves down to the ground or close to it, safe enough to where there will be less likely of an injury. At least that's the hope. We utilize checklists, we communicate, and in flight, we have sterile cockpit times where when we are lifting, when we are landing, when we are searching if there's a lot of birds in the area. There are other critical times when we have to be quiet and eyes out helping the pilot. We are not a weather type aircraft. We don't fly instruments, which means we won't fly in fog or when the ceilings are too low. And bad things happen with that too. We only have one pilot and we are not instrument rated. So we have strict guidelines that we have to follow, but you can't predict the weather either. So when temp and dew point meet, it can happen in an instant, and weather reports are always wrong, right? And if that happens, there are procedures, and we have specific maps and specific things that we're supposed to do that put us on track to an airport or to the closest area where we can land. And we have to know how high to fly up, and these papers that we utilize and these checklists that we use. We practice it very often just in case, because that one time you never know, you don't want to be so scared that you don't know what to do. For EMS, specifically, like ground EMS, there are 3 elements that need to be present: functional and optimized through training and experience. It's hard when it's your first day to know exactly how to handle these things. So there needs to be a leadership component in there. There's a lot of trust that goes with just being kind of a leader. You don't have to have a title or, you know, the beagles on your collar to be a leader or a boss. You can be a leader and lead from within. And so a lot of that does come with experience, and a lot of experience comes with many years of training or mistakes that you have learned from and that you can spread. And so when you gain the trust of your coworkers and you can say, this can help me, this can help us, we can do this, people are more than likely able to help follow or to support those decisions too. There are human factors, good and bad. We need to be able to double check, triple check. And it's not that you've always done something bad. It's QI, QA. This is a process that we're human. We will make mistakes. And if somebody can catch them, they may not be fatal mistakes. Team dynamics. Put the problems aside if there are any, but working on team building, working on that communication and that trust then also will help build some team dynamics. Utilizing your partners as your peer in your arms to help you in this process, and don't fight against it. There needs to be crew resource management. It's just as relevant and important in EMS as it is in aviation. And I will also second that for fire relation also. This So Ted Putnam wrote a paper, and it applied crew resource management concepts to, there was a wildland fire, and they were on a ridge, I believe. This was in 1994, South Canyon fire in Colorado. I don't know if they were fighting from the black or if they got in the green, but either way, the fire got out of hand, and it killed 14 wildland firefighters. So this paper started a movement, and crew resource management procedures were adopted into emergency response situations with stressful environments. So we will also include fire related to it. A lot of states also have fire-based EMS, fire department run EMS as well. So we're all in this together. Even if there are separate entities like a private EMS and a city-based fire, there still will be calls where it is going to be utilized, and you all have to be on the same page. It's been slow to gain widespread traction in EMS. There's lots of books that talk about communication and these kind of topics like checklist manifesto, leadership 360, different things like those. Books are always amazing and fabulous to read because they can be integrated into your work pretty easily. It's something as simple as an innovation, whether it's your delayed sequence innovation or your rapid one. There are still steps and checklists, stroke checklists, something very simple. To not forget to take a blood sugar, because how many people have forgotten to check a blood sugar, stroke alerted, and realized that all along it was just a low blood sugar? I am definitely one of those people that have learned from that mistake. But if there's sort of a checklist or a form to fill out and it's on there, you're less likely to forget it. Entry-level EMS providers learn a lot of how to treat signs, disease, process. Through little training, though, is placed on how to cope with that stress of the moment. A lot of us have seen that first call, critical call. You're a brand new medic of whatever kind, or you have that crazy call, and even yourself, me included, you get in the ambulance or you get on scene and your jaw just drops and you freeze. Right? Or you have the partner that does that and you have to take over now. Even those in the moment stressors are going to take control of you. If you train in a specific way, it's less likely to happen. Leadership in a crisis situation or in a resuscitation event is key and an essential element that can ensure success or failure depending on how it's executed. I don't know if you've ever been on a chaotic CPR call, but to compare it to CPR calls for somebody who has been doing it for 20 to 40 years, there is this moment where you feel like you should be doing something, but you don't need to. But if you're on a chaotic scene where energy is amped, everything is heightened, there's this need and this anxiety, and people who have set the tone for that call, you can feel it. And so if it doesn't come down, it spreads to all the other responders that come to help. And things go wrong, more wrong. Things will go wrong, but more wrong, it feels like, in a chaotic type scene. You need somebody who can lead the call and guide it. Multiple people can. However, we need one clear voice, whether it be a CPR or a car accident. We need one clear voice with set specific instructions for us to delegate and give us that opportunity to reciprocate that leadership in our own role and to be professional enough to do our jobs when we're called upon to do them. Leadership is not merely dividing up tasks or delegating them and ensuring that things are done correctly. There's a lot more to leadership than what we've already talked about. True effective leadership is about maximizing the mental and physical problem solving capabilities of everyone on scene. Something that can be very helpful on scene is, do you see something that I'm forgetting? Do you see something I don't see? What are your thoughts? Asking specific, uh, does anyone have anything that they would think could help? Things like that. Even if you don't know inside and you're freaking out inside, my best way when I lead a call, I feel like, is reviewing verbally. We've given 3 epi. We've done multiple rounds of compressions. We're still doing good compressions. We've checked the blood sugar. We are not getting any change in the rhythm. Does anyone see anything I do not see? Am I forgetting something? And it always kind of makes me take a step down and calm down, because you don't need to know everything as a leader. Effective leaders, they create an action plan. They're going to communicate clearly, simply. They're not going to be better, right? They're not going to utilize words that you don't understand, because nothing is worse than that. They receive, process, verify, and prioritize information. They're going to gather everything that they can, but choose the most important things to mitigate first, and then it will begin to spread from there. Reconcile conflicting information, decipher, oh, we're going this route or we're going this route. Demonstrate compassion, confidence, maturity, have a command presence, and a trustworthiness. So command presence, let's talk about that. Somebody who comes in, who's hunched over, their arms are crossed, it's the middle of the night, their shirt is half untucked, their pants are inside their boots, which may or may not be laced or zipped up, and they're like, why'd you call 911? You know, I know it's hard. I know we've got 2-minute shoot times to get out of bed in the uniform, in the truck. I understand. Being an EMS almost 20 years myself, I get it. It is exhausting. Let alone like the wrinkles in your shirt. How do you get your shirt on and tucked in just the right amount of time, right? It was nice when I was on the engine and could toss on some bunker gear. That was really nice. It could hide a lot of that pajama wrinkle. But when I worked EMS, that was very difficult to have a 24-hour shift and to roll out of bed with 30 minutes of sleep and still maintain a very professional leadership type role, and to be kind and to give grace to everybody on scene, because yes, we're all annoyed that Mama was doing laundry at 3:30 in the morning and fell, and she just needs help up, but it's because she went to bed at 4:00 in the night, and so she just wakes up early and cleans the house. But you still need to look the role. That's going to gain trust. Say you work with different volunteer services throughout, or different fire departments, or other EMS providers come to help, or mutual aid. If you can't even look the part, people are less likely to go to you or to want to think that you're going to be IC or the person that would need to be contacted. A command presence where you look the role, you speak the role, your shoulders are up, your body language speaks. Command presence. It's not a rude thing. You can have a command presence and be nice at the same time. You're going to need to take charge. You take accountability for team actions and outcomes. We all are working as a team. We all are guided and want to do the same goal, have the same results for one goal to save this person or people, or even this house. It's we have actions. However, it's going to be accountable to me if I am in charge of leading the CPR call, no matter the outcome of the patient. I don't want to forget. I don't want to push people aside and be rude and nasty. I don't want people to walk all over me and take charge on top of me. And that can get pretty difficult. But when you go in there and the more it happens with that command presence and with the compassion, that is, you can accept, I'm really sorry that this happened, right? I know it didn't go as planned. There were a few hiccups. Maybe we can talk about it when we get back to the station. Debriefings are always an amazing learning experience. Communication. So this is going to be the cornerstone to everything, every relationship in life. If you want to get anywhere at work, you need to communicate. Your children, if you're a parent, well, if you're not communicating effectively one way, but you really trying, you might need to try a different way. There's many ways to get a point across. There's many ways to be effective at communicating with people. Some people learn differently. You're not always going to affect and hit at the right people with the same message. Sometimes you might have to change that around a little bit. So effective is kind of the key word. When you give direction, it should be with clear, simple words and not too many. When I delegate and I have multiple things that need to be done, like this patient needs things now, all the things, that entire protocol book, all of it, I need it all done now, like yesterday. We only have two hands. If I'm going to give more than one direction or delegate more than one thing, I will only do two because you have two hands. And at least if I'm like, put on ETCO2 and get a blood pressure, okay, that is their role. They'll come to me when they're done, or they'll sit there and I'll see those two things have been done and I will delegate another action for them to do. Idle hands, right? I don't normally let people sit too idle on my scene. And if you are, then I really don't need you. Obviously we're doing fine and we can go now. I do a lot of that. So two hands, two tasks, and it seems to be okay. It seems to help. If not, just give one task to different people. Do not get tunnel visioned yourself. So successful communication and crew resource management hinges on the concept of a closed loop communication. This involves the sender and the receiver understanding of the message and acknowledgement of that message. Lets the sender know that the message was not only received, but received as intended. Give 1 milligram of epi. Okay, I will give 1 milligram of epi. A lot of us are used to that AHA class, closed loop communication. We have to practice it a lot if we've ever taken like a CPR course through AHA or an ACLS. You can have assertive communication. Doesn't mean rude. It doesn't mean that you are coming across as mean. However, sometimes you've got to interject before somebody does something, or you need to get this point across, as in, I'm going to be assertive now. 6 strategies for assertive communication. You're going to hint, which I'm not a big fan of. I don't typically hint unless I'm educating and when there is time to educate, because there is a time and a place. Preference. You can query. Shared suggestions. I am a fan of shared suggestions. Statements are good, and commands. So here are some examples for us. Hint, are you sure this is how we want to do this? If I am given something that is not correct, give 10 million milligrams of epinephrine for the CPR call. I'm going to be 10 million is not correct. You said 10 million. Did you mean 1 milligram? I would prefer this method as myself. However, people will respond. This is a very natural way to respond anyways. Are you sure? Like, am I wrong? And you're right? Or are we doing something new? Did something change and I don't know? Or, sometimes the blind lead the blind. And if you've got somebody who doesn't know your protocols, who you are directing care from, like they may just do it too. So it is good if they're going to return it as a question. There's a preference. I think it's better for us too, XYZ. I do like that. It's kind, but it does show that this might be a better way. And most leaders will say, absolutely. However it needs to get it done and get it done correctly. IV placement. I don't care what size. I don't care where. Just get it done. Don't ask me. You can do it, So a query. What do you think we should do? I talked about this earlier in my CPR calls or when I lead critical calls. And whether I think I'm missing something or not, I will still put it out there for everybody to have that opportunity. Because what if they saw a batch of heroin in the bathroom that I never went into? They just went to go look for medications that the patient might possibly be on, and you could totally have missed that if some people do not have the ability to speak out unless it's being asked. Shared suggestions. You and I should. Statements are, we need to do the following. I am a bigger person on statements and commands when I am leading a call. And that command is going to be, do this now. And doesn't have to be mean. I need you to give me an IV. That's it. So I know that command has some negative feeling with it, but none of this is meant to be in that way. So an appreciative inquiry, another communication recommended for use in pre-hospital care. This is designed to support and empower more junior members of a team to call out or speak up. This is a big thing with me because you see that often. You're newly hired. You want this to be a lifelong place where you get to retire from. You're not going to make waves. Probably not. A lot of people aren't. Or you're brand new. Is this really the way we do things? I've never experienced this before. I don't know, but they're saying this is how we always do things. So an appreciative inquiry also sets the standard to where your voice counts too. To avoid conflict, the team members should use 4 strategies. You need to have an attention getter. State the problem as you see it. Offer a solution. Sometimes you don't know the solution and it's okay to say, I don't know the solution. And then you need to obtain an agreement. If they are not willing to compromise on that agreement, sometimes you've got to either back off. I don't know. I know a lot of fights can come from standing your ground, right? But here are some examples. This one's great. Hey, chief, right? Like I'm going to start with, hey, chief. Maybe my peer, but not my chief. But saying, chief, it's an attention getter. State the problem as you see it. So we're about to initiate a breathing treatment and no one has listened to lung sounds yet. Pretty common, right? How often do you listen to lung sounds? How often do you forget to listen to lung sounds? Let me back that up. I can be wearing a stethoscope and literally hit my patient in the head with it, and I still can forget to listen to lung sounds. If I believe it's a cardiac problem and we're looking at it as a cardiac problem, there are times that I'm not going to listen. You sprained your ankle, I'm probably not going to listen to your lung sounds. I'm more apt to do it when there's a breathing component. So even this statement is just so relevant to our lives. We're going to offer a solution. So let's take a second and listen to them before we initiate that breathing treatment. I want to get a clear baseline. You good? Right? I also like to do the before we intubate, stop. Everybody good? Are we on the same page? Great. Let's go. Or if there's some other critical maneuver that needs to be done, that will also give somebody the ability to safety, to call, hey, no, I see this, or let's fix this really quick. The lead fell off. The SpO2 sensor came off. Something, their foot's dangling off the stretcher. That will lead me into timeouts. Timeout. Who can call a timeout? Anybody. Even if you have the old man volunteer in a blue helmet that is called safety officer, it doesn't matter. Anyone can call a timeout. It doesn't have to be lead. It can be a driver of any kind. It can be anybody who can see something is about to go wrong, or something, I've got a concern. Something isn't sitting right. Speak up about it. The preemptive approach is most effective when a checklist is utilized to ensure everything is in place before moving forward with a procedure. We do checklists, and before flight, before lifting, we do the pilot. We call it a challenge. The pilot will ask us if we have everything: NARC keys, equipment, oxygen. Is everything secured, right? And then we challenge, they have a checklist and it's there and it's procedure wise. And we will still ask about fuel. Is dispatch, did they acknowledge, are we ready to lift? Different things. What are our engines? Do we have any lights on? Those kinds of things. We ask, and it is a must, because that one time you don't, you're going to leave your narcotic keys at base and you're going to get on that call and absolutely need them for sure. That's happened to me too, where I went to go take a transfer on an ambulance, and I show up to the hospital and my narcotic keys were on my nightstand. And what did this patient need? Pain medicine. So I made sure that they got a good dose in the hospital before we left, because there was no backtracking and going to go get those keys. They're utilized anywhere. Checklists can be utilized for everything. You can bring them into your house, right? We can do it in our personal life. It's a major role. Checklists are great. Sometimes they can be utilized too much, but they're meant to be used to prevent catastrophes from happening, problems, dangerous things from happening. Surgeons will use checklists, and not just once. So they make a list of everything that is used, everything that is on the trays in a surgical suite is in a checklist. They will call out every tiny item, not once, not twice, possibly more than 3 times too, to make sure that their items are not closed up inside of you, or that they're not missing something. Right? Clamps. It can get hidden. You put the organs back on top. If you had 3 clamps to start, now you have 2. Obviously, we need to go back in and look. So we're not sewing this patient up until we have those checklists completed. And then even afterwards, even when you are closed up, I've been through some surgeries in the recovery room where I heard them go through it twice again to make sure that everything was still there, which is a good feeling, especially when everything is there. So surgeons even utilize checklists. Um, so all teammates should feel empowered. I'll say it again. I can't say it louder for the people in the back row, but all teammates should feel empowered to call a timeout. This is able to, you can address safety, patient care concerns. Even if it's silly, you feel silly. You're like, hey, is timeout, is that correct? Oh, and timeouts are amazing on when the family is crazy on scene. Oh, they're trying to get in the ambulance and the cops are just trying to keep them at bay and people are screaming and crying and you've got this pediatric patient and it's difficult. You have to start locking the ambulance doors or things like that. Like timeouts can be needed, even if it just is a second just to gather and okay, start, let's go again. It can do wonders for your call. So there is a human factor. I feel this is a really important slide to talk about. The controllable factors stem from making good decisions long before an error occurs. You need to get enough sleep. You need to learn how to focus appropriately, engage in your education and training appropriately. So the U.S. Air Force did a study of aviation mishaps between the years 1992 and 2002. What was found was 18% of its aircraft mishaps in the Air Force alone were directly attributable to human error in maintenance. Interesting, huh? When our aircraft is down and my helicopter at work, when it's down and the mechanics are working on it in the hangar, I will rarely go in. It's got to be a big deal for me to go in there. That is a distraction for them. If you've ever looked at any mechanic's toolbox, my dad was an airplane mechanic in the Air Force. He had styrofoam and inserts, and every tool had its spot, just like the surgeons. If there's not a tool back in the drawer of where it's supposed to sit, you need to go find it. Is it on the aircraft? Is it sitting on the wing? Is it underneath? Did it fall? Did you leave the tool? I know I had my oil changed and I had a wrench under the hood of my truck when I got home. But in an aircraft, that is deadly. That is absolutely deadly. I've seen things where spools of metal have been left. Now, that doesn't have a place in a toolbox all the time. So checklists need to be utilized. To error is human. We are human. But to get a second backup person to help you go through to make sure you have everything, that's another thing that we do as well when we go back in service for big maintenance. The pilots, another mechanic, will back up the original mechanic and they'll go through some things. So I don't want them also to feel rushed because that's a lot of stress. Think about when you just had to take your first ever manual blood pressure. Say it was at the side of a highway and you could barely hear, and you had these cruddy stethoscopes, and your preceptor's standing there, and you're on your clinical write-outs, and they're like, "Hurry up!" That stress makes you just not hear. You can't do anything, and so you don't want anyone to feel rushed. They need to move with purpose and it needs to get done. Something does need to be said if people are lollygagging, but things need to be also done correctly. So slow is smooth, smooth is fast sometimes, right? Skill-based errors. When a provider fails to pay attention to what he or she is doing, and through poor technique or just taking out a step, omitting a critical step, fails to perform the skill correctly. No shortcuts. No shortcuts. Once you start cutting things out, it becomes a habit. Now your habits create lifelong poor decision making from there in skill-based situations. Uh, these can be deadly. It's a drift, a kind of drift, complacency, a just culture atmosphere. Decision error is divided up into two types. You can have honest mistakes. And yes, we all have done them. I've spoken a lot about my mistakes in this class already. The provider does as intended, but selects the wrong treatment pathway. I swear it was chest pain. They had no reason for it to be asthma or something like that, right? Perception error. When a provider loses awareness, their brain begins to fill the gaps to make the information complete. We will still connect the dots, even with things that didn't happen. Situational awareness. If you see something unsafe or if you notice something is going wrong, say something. Speak up. You've got three elements. You've got a perception, a comprehension, and a projection. The perception is our ability to discern what's happening with our patients or a particular situation. We've got the comprehension aspect of it. We have to know not just that our patient is sick, but why they are sick. This is the stage where we make our differential diagnosis, and this is our attempt to discern why the patient is sick. Our projection, we need to use the perception and comprehension to project the future, the status, the clinical course of action for that patient. Tunnel vision. If you tunnel vision yourself, a lot of times you can miss a lot. Sometimes if you can pull yourself away and look at a bigger picture, things can come to light, especially in those tricky situations, those difficult situations. Elements that affect cognitive thinking. This one's a big one, right? A lot of us have trouble sleeping. A lot of us have lots of other trouble. Peer family dynamics, anxiety, alcohol, substance abuse, depression, sleep problems. To correctly perceive, comprehend, and project a clinical situation, it requires incredible clarity in thought and experience. The more you're on calls, the more you've seen it, the more you can log, and you can kind of, you get it. You just got to run those calls, right? But however, if we've been up all night on a drinking bender, slept 3 hours, are predisposed to having anxiety as it is, and especially having anxiety when we're stressed, we can screw that up pretty big, right? There are a number of variables that can negatively impact that ability to think, understand, and to make appropriate decisions for your patients, for yourselves, for your partners. These elements not only affect thinking, they're going to affect your behavior and your attitudes. It bleeds into work ethic, and it can change your work ethic, and it increases negativity as well, which then decreases the morale and that brother-sister atmosphere that we have in first response. In the flight world, we use the acronym DEATH a lot. So you'll hear DEATH. It stands for drugs, environment, alcohol, tobacco, hypoglycemia. Those are things that can have a deadly effect. If you were someone you know that's in need of therapy, counseling, talking to someone, there are a lot of resources out there. It's just stress management. Something as simple as sleep therapy. It may not be for mental health issues, or it may not need to be for depression, or PTSD is another big one. But speak up. They might need help but can't say it, or they may not recognize that they need help. The framework for enhancing human performance. We've got training skills to mitigate performance issues. Appropriate training. I know it's hard not to get into the training room and start giggling and laughing, and the mannequin does something silly, or you do something silly to the mannequin. But there comes a point in time when you need to start practicing like you're going to play, right? Don't train where you are going to give yourself bad habits. Don't train with the wrong technique. If you don't know, ask for help, or find somebody who does know, who can train with you appropriately. There is a time and a place for being silly, though. We all need it for sure, but we also need to be able to do our jobs very appropriately. We need to improve our resilience, our bounce back. We need to enhance performance under stress, reduction of any stigma associated with getting help, to overcome one of the performance barriers. The result in implementing this framework would be better focus, faster recovery from stressful events. We are expected to bounce back very quickly, and run very traumatic calls, go clean the ambulance and do it again. And better decision making under stress. These are very hard things to do. Application of crew resource management. Many agencies have implemented crew resource management in day-to-day operations. Your checklists, protocols, procedures outline this implementation. Studies show that the most successful resuscitation teams observed show significantly more leadership behaviors and explicit task distribution. Another study showed that after implementation of crew resource management, communication amongst team members was better. In conclusion, crew resource management is the use of leadership and communication to leverage the collective power of the individual team members to enhance team dynamics. This also reduces the negative influence of human factors on patient care in the day-to-day operations. Crew resource management is about safety for the provider and the patient, affecting the behaviors through the use of checklists, communication strategies, and leadership. Ambulance safety. We will describe the dangers associated with ambulance operations and patient transport, describe major types of ambulances, their key components, legal issues that are related to unsafe ambulance operations. Napoleon's chief surgeon dedicated specific carriages. He would transport wounded patients from the battlefield in to go get treatment. So in 1862, the Union Army organized the first military ambulance corps. 1865, Cincinnati became the first American city to have ambulance services. A few years later, New York and Boston followed suit. Initial staffing of ambulances was with ill-trained personnel, firefighters, police, funeral homes, wrecker services, and hospitals. This is a big one. Can this happen to you? And yes, it can. I've been in several fender benders myself, but one major ambulance accident. And thankfully I was buckled in We did not have a patient in the back, and we were coming home in the middle of the night. My partner was driving, literally 2 hands on the wheel, 10 miles under, and it was just a little drizzly. It was 1:30 in the morning, and we flipped the ambulance twice. We cleared a fence, and what stopped us was a tree, a big tree, which got just directly behind her door, but kind of in the front part of that cab. I knew it could be bad. It felt like we rolled 6 times, but we didn't. Everything was kind of in slow mo. She was more hurt than me, thankfully. I just had more seatbelt type injuries, and thankfully nothing internal from that. She actually had injuries. So coming out of that all bruised, you initially look at my partner who was driving, and she's freaked out. She's scared. She's awake. And I did a quick, all I could touch was her face and her shoulders. There's no blood. And, but you quickly kind of touch yourself and you're like, okay, we're alive. You find the radio, but the siren was activated. The radio was activated. It was blasting and it was loud. The lights were activated, and we were down so far that people could not see us on the highway. And it was busy. No one stopped. And it took them a while to find us too. And I wasn't going to leave the ambulance without her. None of the airbags deployed. I think her side curtain deployed. Mine did not. I don't even know if I had any. I think I did, but either way, when you get to the hospital and you get your snacks, well, this particular hospital that we dropped off had sandwiches for us. Well, she doesn't like the tomatoes on her sandwich. So she put the tomatoes back in the little plastic container and stuck it right in the middle. And it was there, no problem. But when you go tumbling and rolling, everything gets open, literally. All the sharps came out of our sharps container. Cabinets, everything came out of the cabinets. Everything. The doors were all open on the outside. And the tomatoes, which is going to be key here, the tomatoes fell out of that little plastic thing. Now, I didn't know. So I look at my pants, and I swear to God, I have brain matter on my pants. And I think it's my partner's brain matter. So I'm looking at my pants after I talked to dispatch on the radio, and I'm looking at my partner, and I'm looking at my pants, and it's dark and you can't quite see, and you're touching it, it's gooey, and you're like, where is this brain coming from? It's not coming from me. So did it come out her ears? I don't know. And I would touch her face again, and I wasn't quite telling her what we were doing. And so when we get out of the ambulance and I get into the light, and we both did not want to go in separate ambulances to the hospital. So we took the same ambulance. I just sat in the captain's seat. As when finally I realized that was tomato. Thank goodness. So that was a really crazy experience for me. Other times I've actually been hit head on, but just so where the mirror was taken off in the front corner of the ambulance box, because they're in your lane and you veer and you got to get away, and it gets hit still, but you're okay. That happens a lot. There are times where it is your fault. So you do have to have that due regard when you drive. So it's a dangerous profession. Crashes that involve other vehicles are the leading cause of death among ambulance crews. Ambulance crashes account for 74% of all fatalities in EMS professionals. From 1988 to 1997, 305 EMS responders lost their lives in crashes, which was nearly twice as many as fire service personnel. The department I worked for had someone who was drunk in the middle of the night, almost in the same location. They were coming back from a transfer, same thing. They were hit head on. And it just so happened to be a friend of mine's brother who worked for the department, and he died on scene. His partner never returned back to EMS, but she did live through it. And so it hits close to home. Major types of ambulances. You've got type 1s, 2s, and 3s, and some are a little bit more heavy duty than the other. Your type 1s are going to be a more light duty ambulance. It's got the ambulance body built on a truck chassis. The person has to exit the cab and to enter that ambulance box. Weighs 10,001 pounds to 14,000 pounds gross weight. The type 1 ADs are medium duty ambulance. It's much like a standard type 1, but it's built on a larger truck chassis. This ambulance has increased payload and storage, so 14,001 gross weight or more. Here's your type 1. Here's your type 1 AD, a little bit more heavy. It's beefier looking, isn't it? Type 2s are going to be your van ambulances, I think is what a lot of us call them, vans. Van-like body with an integral cab body with raised roof. These are tight, aren't they? There's some tight space in there. The entire ambulance must be replaced when it reaches the end of its usefulness. You can't just lift the box, remove the truck and the chassis, and put a new one in, put the box back down. It's called a remount. Can't do that with these. The weight is 9,201 pounds to 10,000 pounds gross weight. Here are type 2 ambulances. Your type 3s and type 3 ADs. Type 3s are a long wheelbase van chassis, has the rear of the van cut out and away, but it allows for the ambulance body to be attached. Weight is 10,001 pounds to 14,000 pounds. Type 3 AD ambulance boxes are mounted on a commercial chassis. Has the rear of the cab cut away for box placement, over 14,001 pounds gross weight. Here's your type 3s. I've worked in all three, mainly type 1s, and I prefer the type 1s. I did like having the ability to climb through, to have the breezeway between the ambulance, the front and the back. That was nice at times because it gave me more the ability to talk with my partner who was driving, or vice versa. Legal issues. The personnel operating the ambulance, as well as that entire EMS system, can be held liable for criminal and civil lawsuits. Duty. This is going to be referring to the responsibility to act or perform in a relationship to the position that one holds in accordance with industry standards. You are held accountable as somebody in a different state with the same situation, what they would do. There is a national standard. Liability is going to refer to that concept of being responsible for one's actions or inactions. And then a causation comes to play when another person or patient is further injured or suffers some other type of damage as a result of action or inaction. There's a negligence component. A litigant will attempt to use those three factors, to prove negligence in a civil lawsuit. There is a gross negligence, which is reckless disregard for the safety of others and property. And a simple negligence. You didn't mean for it to happen, but it still did. Something still occurred. A breach of duty. The plaintiff must show that the defendant had some duty to act, and it was breached. It was not done. The plaintiff must also prove that the defendant failed to adhere to acceptable standards, the accepted standards of care for that specific profession. While the ambulance is used as a day-to-day office, it is vital to the care of all of our patients. You need to know the limits to your ambulance that you're operating. It's vital to your job. This is your office space. The responsibility of EMS carries the possibility of legal liability in civil suits as well as criminal cases. Knowing the legal side is just as important as knowing how to properly care for your patients. Our last topic we're going to talk about is pre-hospital exposure to infectious diseases. We will describe the general pathophysiology for infectious disease process. We'll identify common infectious diseases and their clinical presentations. Pre-hospital provider exposure. The leading injury is sprains and strains. The second leading injury to providers is exposure to harmful substances such as infectious material. And in EMS, we deal with it every shift. In 2013, the National Institute for Occupational Safety and Health reported that there were 20,200 injuries to EMS personnel that divvied up into 32% were overextension and body reaction. 20% were harmful exposures. So that's your second leading cause is exposures. Contact with objects and equipments is going to take 15%. Falls, slips, and trips, which I personally thought was way more than this, but it's 11%. Transportation incidents are 11%. And violence will account for 10%. Forms of infectious disease. It spreads in many different ways. You can have bacteria, virus, fungi, parasites. Bacteria are single-celled organisms such as strep throat or tuberculosis. Virus is smaller than a bacteria. It causes the common cold, AIDS, requires a living host to replicate themselves. Fungi can be a number of skin diseases like ringworm, athlete's foot, and parasites. They cause sickness from bites like malaria from a mosquito bite. Direct contact. This is going to be a process of catching an infection by coming in contact with a person or an animal that has that infection. Person to person is pretty obvious. So that bacteria, germs, viruses pass from one person to another after the infected person coughs, sneezes, wipes their, if any of you with kids, we all get sick in one house together, right? Typically when one goes down, the whole ship goes down with it. Like it is hard not to catch the flu when your kid has the flu and they've been all next to you the last few weeks. Viral shedding and incubating. And great. Let's all have the flu now. So we've gone through a lot of illness in my house, and hopefully our antibodies have now built up from kindergarten. So person to person is pretty direct. You've got your animal to person, and the first thing a lot of us think is rabies, right? So animal to person is a person is infected after being bitten or scratched by an infected animal. The handling of animal waste can also cause transmission. Excuse me. So let's talk about rabies. Rabies is a deadly virus spread to people from the saliva of an infected animal. It's usually spread through animal bites. Animals that are most likely to have rabies are dogs, bats, coyotes, foxes, skunks, raccoons. If a bite occurs, treatment needs to be immediate. There's a series of immunoglobulin shots and vaccine shots that need to be administered immediately. And it will cut if rabies is contracted, or the dog that bit you in the leg is rabid, it will more than likely not develop because of this. If you know where the bite is, you can get a series of shots around the bite. The immunoglobulin ones go around the bite, and then you get the vaccine. And then you continue to go back for your rabies series. People like animal control officers or wildlife rehabilitation that deal with raccoons, or other with foxes, and with any kind of animal, you can also get that rabies vaccine ahead of time, knowing what you're in for. I have a friend who has a raccoon rehabilitation. Her entire family has the rabies vaccine, but they do amazing work. So I do know that bats, if you don't know you're bitten, bats also have the capability of biting you and you not knowing it because it's so tiny. They carry different strains of rabies as well. So if treatment is not done, and symptoms do occur, it's more than likely going to be fatal. It is very likely that it is going to be fatal for you. Symptoms are pain in all your muscles, dizziness, loss of appetite, fatigue, delirium, hallucinations, sensitivity to light, aggression, irritability, nausea, vomiting, many others. People have lived who have had symptoms of rabies, but it is very rare. Other animal to person diseases that you can catch, there's many that you can catch. Another common one is like a cat scratch fever. This is an infection in the lymph nodes after a scratch or a bite from a cat. This disease is caused by a very specific bacteria that is on them, that is now inside of you, that you react to. Symptoms are going to be flu-like symptoms, red bumps, fever, fatigue. Your lymph nodes near the site of the injury or closest to that site swell because they're trying to correct and they're trying to get rid of that bacteria. Antibiotics will more than likely be needed, but this disease can clear up on its own. It just takes time. A lot of times if you get scratched near a joint, that joint will swell. And that the pressure and antibiotics do need to be administered for things like that. Trichinosis. This disease is caused by a microscopic parasite, typically obtained by the human by eating raw or undercooked meat from an animal that's been infected with this parasite. The most common infected meats are wild game, like bear and pork products. Early signs are more nausea, vomiting, diarrhea, fatigue, fever, abdominal discomfort, headaches, fever, chills, cough, and swelling of the face will follow. And if severe cases are not treated with antiparasitic drugs, this disease can be fatal for humans. There are many others that can cause a multitude of symptoms that can be similar to these as well. But these are kind of some common ones that we'll come across. We can also have a mother to unborn child type of contact. They can pass an infection to a child from the placenta. Indirect contact. This is always fun because was it the doorknob at the hospital, or was it the shopping cart at the grocery store that got you sick? Or neither. Germs that are passed from one person to another through inanimate objects such as doorknobs, faucet handles. When a person that's infected coughs on their hands and uses the doorknobs, and then you're right behind them touching it, just like we do after our own children in our own house. Another way to spread it is through food and water containing bacteria. A lot of this is done in underdeveloped communities that don't have access to running water or clean water or toilets. A lot of people who wash their clothes in the same river that they use it as a toilet. And whoever you want to be that first one upstream, because the person that's way downstream catches everybody's stuff, right? But they also don't have running water or toilets in their house. Things are not livable conditions. The consumption of an infected water source or food source can spread these germs to many people. Many people. Other forms of transmission. You've got a droplet contact. A lot of us went through a COVID experience where you intubated a patient in an emergency room, and now the doors have to be closed and airtight. Everything, the patient's now moved out, or you just have a COVID patient in an emergency room. Everything has to be, leave it alone for 30 to 45 minutes and let everything settle. All the airborne, the drops in the air, especially if they're aerosolized, right? So we weren't allowed to do nebs at that time because you can't see it. They're tiny, 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 and they're floating around out there. Let them get to the surface, and then you go in and you deep clean and you sanitize, and you really do a good job of getting rid of what you can. That we went through a lot of that. Some droplets some are bigger than others, but you do also need to allow enough time for them to settle, because if you clean and then it settles, it defeats the purpose. Airborne transmission is when the germs are present in the air and are transmitted through natural airways. You're just breathing in. People are coughing and sneezing. It's in the air. Anyways, fecal oral transmission. A lot of this is spread through the feces of a person. So not only from the rivers, the third world countries can spread that, but just your local restaurant where the person did not wash their hands and they cooked your food. Vector-borne transmission is a vector is an animal that is capable of transmitting diseases, fleas, rats, ticks, big ones. And I put this picture up on this slide for ticks. Look how tiny some of those ticks can be. Lyme disease is more prevalent in the Northeast, but it can be found anywhere. So common infectious diseases. This slide's always a fun slide to talk about. So AIDS, HIV, we can contract it, or a person can, through needle sticks, blood splashes into mucous membranes. Let me preface this slide. Let me rewind this for just a minute, right? The CDC reports that 99.7% of needle sticks and cut exposures do not lead to infection. They also report that there are over 385,000 healthcare workers that are accidentally stuck with needles every year, dirty sticks. So put that into perspective, because sometimes these numbers seem huge when you say them. But the chance is still there. AIDS and HIV, you've got needle sticks, blood splashes into that mucous membrane. So a person with AIDS or HIV goes into the ER. That healthcare worker accidentally sticks themselves with that needle. 1 in 300 dirty AIDS, HIV, accidental needle sticks will give somebody HIV. They will get infected from it. That is 1 in 300 positive HIV hospital cases. And those numbers can add up and get very massive throughout the year through all the hospitals in the US. So the numbers it's very slim chance. It does exist because it has been known to happen before. Hepatitis A, you can get it fecal, oral, contaminated food, water, close contact. Your roommates. I was vaccinated because I was already in healthcare, and I had a roommate who had hepatitis. I think it was hepatitis A. He cooked breakfast for everybody in the house except me because I was at work, and everybody in the house came down with hepatitis except for me. So I'm assuming it's because he cooked the breakfast, his birthday breakfast. He never cooked any more than that. So I'm assuming that's what it was. It may have just been the fact that he was the roommate. They all came down with flu-like symptoms. They all turned yellow. Their poop turned white. It's kind of crazy. Hepatitis B, get it through dirty needle sticks, blood exposure to the mucous membranes. So some statistics for this. The chance of getting hepatitis B can be as high as 1 in 3. So this is more for the healthcare worker who is not vaccinated. Repeat, not vaccinated. And so that is going to be, the CDC reports that is 5,100 workers every year become infected with hepatitis B from a dirty accidental needle stick. That's a big number. So job-related blood contact, that may not be needle sticks, but either way, there is a transmission in 5,100 workers. So the chances of you getting hepatitis B is way higher than you getting AIDS, HIV. A lot of it is done with the hollow bore needles and not utilizing safety equipment like the quick sharps technique, or clicking down, recapping. I know we're not supposed to, right? Recapping your needles. So hepatitis B can be stable in dried blood for up to 7 days. That's a big one, right? So contaminated surfaces, benches, seats, equipment. If it's you handle a patient, you grab what I call the monkey bars on the top of the ambulance, you open the door handle, you might decon that ambulance spotless, except you forget the door handle on the inside. It's still there. So when you check off your trucks or you decontaminate your trucks, wear gloves. Be very conscious that sharps can also roll and fall under cushions too. So be very diligent and be very careful with how you're cleaning and what you're cleaning. Try to see it before you just run your finger along the bottom of the cushion and you find that 18 gauge. Wow. Yeah, that's happened to me. So hepatitis B was always a fun one. Hepatitis C, there are medications that will help bring it down to remission, but there is not a cure for this one. This one is contracted with blood contaminated with the virus. With blood contaminated with the virus. It's going to be an STD form. It's going to be a dirty needle stick. It's going to be drug users. And it can be with healthcare providers as well. Influenza is airborne. It is. It's a virus that travels through the air in droplets from an infected person. And a lot of times that person doesn't have signs or symptoms yet. and they're a viral shedding and you're just with them and you get it that way. Now they have symptoms and you're like, uh-oh, right? My kid. We just recently went through what I think was the flu. I know it wasn't COVID. More common infectious diseases, meningitis, bacterial or viral, respiratory secretions, sneezing, coughing, what that guy is doing and you being in the way. Spreads like wildfire. You can also have a fungal meningitis, which actually is really, really bad too. But meningitis in general is a very painful experience for a lot of people. Whooping cough, airborne from droplets, direct contact with oral secretions. Tuberculosis is airborne. You can also be a TB carrier. Someone in the family has it, they were treated for it, you test positive for it, but you don't have signs and symptoms. You can be a TB carrier as well. Pneumonia is airborne. Inhalation of virus and bacteria expelled during a cough or a sneeze. Also blood contact. And then infamously, Ebola. I don't know if you guys remember a couple years ago when it was really big in the US, how we had to have our Ebola kits on the ambulance with plastic cloth drop downs and all the Tyvek suit stuff, more than the COVID stuff, right? So in conclusion, with the use of your proper PPE, you can minimize your exposure to infectious diseases. What do you do if you do get a dirty stick? Who do you report it to? You wash the area immediately. You need to speak up, fill out the paperwork, report it, let it be known. Know who you need to go to. If not, you need to find a supervisor. If you're dealing with blood-borne patient, possible hepatitis B, AIDS, something, or you're not sure if what they told you was the truth, you need to go to the hospital. You've got to get tested and you need to get on your prophylaxis care too. So if exposed, follow those local policies, those procedures. They're in place for a reason. And yes, everything is tracked, but for good reason. Wash all exposed areas. Cleaning and disinfecting is the key to preventing cross-contamination. And I'm going to add one more thing on that. Cleaning is different than disinfecting. You can wipe something down and clean it. You can disinfect it by following proper disinfecting techniques, utilizing your chlorine bleach where needed and wiping things down very appropriately, letting your Cavicide sit for 10 minutes. If you haven't read the label, it needs to sit for 10 minutes after it's been saturated. So a lot of us spray and wipe, which probably does good anyways. However, it even states on the bottle that it has to sit. It's hard, isn't it? It's hard to do this. Mixtures of bleach and water in spray bottles has always been a good thing to clean with as well. So thank you very much. Have a good night.